Today, I would like to share a few stories with you. Although they are powerful and compelling, unfortunately, there are many healthcare workers across the globe who share similar stories. Meet a few of my TB-proof friends.
I'm Pumeza Tisile, I'm 26 years old, I'm from Khayelitsha, Cape Town.
Ek is Werner Geldenhuys, ek is 'n gesondheidsinspekteur, werk vir die stad Kaapstad, 33 jaar oud.
My name is Pat Bond. I'm a registered nurse by profession. I live in Somerset West.
My name is Zolelwa Sifumba. I am originally from East London. I'm a final year medical student at UCT.
So it was in 2010, and at the time here it was the Soccer World Cup. So I was a first student at CPUT. I saw that I wasn't well. I wasn't coughing or having night sweats or anything like that. But there are stairs there, but it was difficult for me to climb those stairs to get to classes. And I was losing weight dramatically. So I went to the private doctor. The doctor checked the common diseases, diabetic, high blood pressure, even HIV, they all came back negative. And then he saw that there was really something wrong with me, which he gave me Panados just to get rid of the fever. Then from there, he just said, no, go to the public clinic to get tested for TB because private doctors don't test for TB. So I went to do a chest x-ray. Then from the chest x-ray, I remember him saying this, wow, this is bad because at the chest x-ray, there were holes there. You know, the chest was supposed to be black, but mine wasn't black, like dark black. It had spots there. So from there, he said I had TB.
I was working in a dialysis unit in Claremont in Cape Town when I became ill in about the September of 2010. And initially I was diagnosed as having pneumonia and I was put on antibiotic treatment and I just didn't get any better. Eventually in the December when I started with night sweats, a bell rang in my head and I realized I'd better go for more tests. So I went for another set of x-rays which showed probable TB, query pneumonia. Obviously, I had to leave the unit straight away.
Ek het TB ontwikkel as gevolg van die tipe werk wat ek doen in die areas waar ek gewerk het en dit het al skielik gekom. Ek het skielik begin hoes en ek het begin bloedhoes en geskrik en geweet regtig wat aangaan nie en ek is ongevalle toe opgeneem. Hulle het 'n paar toetse gedoen dadelik. Toe het hulle my gesê maar ek kry niks op daai oomblik reg verkeerd nie. Ek kan my huis toe gaan as dit weer gebeur moet ek dadelik inkom. En toe 2 dae daarna toe ek heelwat meer begin bloedhoes. Groot geskrik, dadelik teruggegaan hospitaal toe. Toe in daai 2 dae se tyd toe die verslag van die een toets teruggekom. Toe sê toe is ek nou gediagnoseer met TB.
When I was doing 4th year, we were at a hospital in Cape Town. And obviously, you know, going into clinical medicine, you know, the clinical years, we start working at the hospital with patients. You hear about TB, and people tell you to protect yourself from TB, but, you know, you're not really sure what it is, where it is. So I woke up the one morning and I had pain on my neck on this side. And I was like, what? Just randomly out of the blue. I had a lump about 3 by 3 centimeters. I went to school, showed my friends, and we're like, oh, maybe it's TB, you know, just shooting out differential diagnoses, but like as a joke, you know, oh, maybe you got lymphoma, ha ha ha. Ah, it's not TB, it's not TB, we don't get TB. So I go to the hospital, to Curtis Gear, and yeah, speak to a doctor there. And immediately he's like, hey, you're a medical student, right? So what do you think this is? And I was like, no, this is not the time. This is not the time. Yeah, he said to me off the bat, like, this looks like TB. They did a biopsy. And as the second doctor's doing the biopsy, he's like, hey, you're a medical student. Do you remember what TB looks like on a biopsy? I was like, yes, caseous necrosis. And he's like, yes, that's what you have. I was like, no.
Initially, the diagnosis was just TB. But within a week or so, it came back as being multi-drug resistant TB, which was quite a shock to me. I eat healthily and it was quite a scary situation. It was, you know, totally being on my own, nobody to support me.
So I was given normal TB drugs for about 3 weeks, like 3 tablets. And I took them, but then I wasn't getting any better from the drugs. So next thing I know, I woke up in Calbrem Hospital. They said that I passed out. I can't remember that thing. So when I woke up, I couldn't walk. I couldn't use my right hand. it was actually dead. And then they checked again for my TB. Then it came back. Then it saw that it was not normal TB, but it was MDR TB. So it was difficult to get the MDR TB drugs to Kalbrema because it's not a TB hospital. 20 tablets a day with an injection every day. So it's like they observe you while you take the drugs. It was hard, but then they had to squash them all, put them in yogurt or in water so that I can take them all at once. But then I will vomit because it's disgusting.
Dadelik het hulle sê reg, jy moet nou dadelik begin op jou 6 maande behandeling, pulmonêre TB, en al my kontakte moes ook getoets geword het. So op daai stadium glad nou nie geweet waar dit vandaan kon kom nie. Ek woon in 'n doodnormale huis. My vervoerswerk toe was met die motor geweest. So ek het nie in publieke vervoer gebruik of in baie groot publieke areas beweeg nie. En ek het my werk laat weet en gelukkig die bestuurder wat ek op daai stadium gehad het, hy het gesê maar hy dink ons moet daar solank die vorms begin invul net vir ingeval vir 'n beroepshigiëne siekte. Dit gedoen of hy het dit vir my gedoen want ek moet nou nie terug aan werk toe nie. Pulmonêre TB so 2 weke, 2 na 3 weke moet jy uit weet jy al vir die samelewing onttrek. Dan behoort jy fyn te wees. Dan is jy nie aansteeklik nie. En dan kan jy terug aan werk toe. So is tog dan cool. Dit sal nou goed uitwerk.
And then a few days later, I got a phone call Saturday afternoon from a lab tech. Like, Zolelo Sefumba. I'm like, yes, speaking. They're like, so your results have come back. You've got TB. It is rifampicin and INH resistant. So go to the nearest clinic. You've got MDR. So this is throws on the table about 21 different pills. I was like, what is going on? I'm on my way out. They're like, no, honey, injection. And that was the worst injection I've ever had in my life. It literally feels like they're putting hot lava into you and it aches the whole day. Side effects were so bad. I was vomiting every day. I was nauseous. I had diarrhea. I had insomnia. My joints were painful. I was scared that I was going to lose my hearing because I went through the packs of some of the pills and I was just like hearing loss, liver damage, kidney failure, all of these things, psychosis, and I'm just like, what is this that I've gotten myself into?
I was taking the MDR TB drugs, no? They transferred me from Kalbrema to the Brooklyn Trust Hospital, which is a TB hospital. So I was there for like a year, but then while I was there, I think 4 months, I woke up. It was quiet. So I went to the bathroom, flushed. There was no sound of anything. So I thought maybe there was something blocking my ear. So I took an earbud just to clean whatever that was there. There was no sound. So I told the nurse that I can't hear. Well, I saw her moving her lips. There was no sound coming in. It was just like something out of a movie. So I remember they wrote on my folder, on capital letters, deaf with an exclamation mark. She had to write down, I had to talk, and then it was awkward because I could not hear myself, and I couldn't understand what was going on. But then she explained, no, it's the kanamycin injection that we've been taking. It is, the side effect of it is deafness, so you experience that. And she said she was sorry, there's nothing she can do, blah, blah, blah. That's just crazy.
It was, roughly speaking, 30 tablets a day I would have to take. And they're not sugar-coated or encapsulated tablets, they are vile. In fact, if I smell one today still, it's not a very pleasant experience. I developed terribly painful joints. I lost a lot of weight. I couldn't dress myself. I couldn't drive anymore. And the decision was made that they would remove the disease part of my right lung so that I could possibly come off treatment somewhat earlier than the routine 24 months. So I had a lower lobe resection, and that was also quite something, being a professional nurse and undergoing surgery and all of that kind of, it's just weird to be on the receiving side instead of nursing somebody who's going through it.
Hulle het my op pulmonêre TB behandeling gesit en ek het my medisyne geneem, pligsgetrou, en na 2 weke het ek teruggegaan werk toe en alles was fyn. Maar ek het gereeld vir opvolg gaan, of elke week daarna moes ek vir 'n opvolgbesoek gaan. Die een toets wat hulle doen om te bepaal of jy wel nou nog TB het of 'n reaksie is op die medisyne, neem so 6 weke vir die uitslag om te kom. So ek het die toetse gedoen en teruggegaan werk toe. En toe op 'n stadium met die kliniek na weer gegaan het vir my medisyne, vir my laat weet, luister, ek gaan op 'n 2 jaar MDR behandeling moet gaan. Dit was rof, want 2 jaar is 'n bitter lang tyd. En ek het, alhoewel ek 'n gesondheidsinspekteur is en al baie met mense gewerk het wat nie wil teruggaan vir behandeling nie, en dan word ons baie keer gevra om met die persoon te gaan praat en om te probeer oorreed om terug te kom na die kliniek toe vir sy behandeling. Dink ek nie het ek regtig begryp wat aan die gebeur is nie. Ek het met die behandeling begin en of eers my familie by mekaar gekry en luister, dit is wat nou gaan gebeur. Ek het 2 jaar op behandeling gaan. Wonderlike ondersteuning gehad van my familie. Hulle het my regtig op die hande gedra en ondersteun, en die een medisyne is 'n inspuiting wat jy elke dag moet neem. Die maklikste manier om elke dag 'n inspuiting te neem is in jou agtersteewe. En na tydjie raak dit ongelooflik seer. Jy kan nie stap nie, jy kan nie ry nie. Toe het ek deur 'n kollega gehoor van professor Wilcox by die UCT privaat hospitaal. En hy het vir my gesê, maar hy kan vir my met 'n port insit in my bors, dan kan ek my inspuitings self doen. Op daai punt was dit vir my wonderlik geweest om dit so te kan doen. Hy het toe besef dat die inspuiting wat ek gebruik, daai spesifieke medisyne werk ook nie soos dit moet nie. Die TB-diagnose is toe gemaak as toe pre-XDR, en dit beteken nou maar net dat die een inspuiting nie werk vir jou nie.
9 months to the pre-XDR TB drugs, the drugs stopped working, so they told me now that I have XDR TB. That's like the last stage of TB.
Hello everyone, my name is Dr. Tato Musidi, and like my friends from TBProof, I am also an XDR TB survivor. Thank you for making the time to hear our presentation. Healthcare workers are more likely than the general population to be infected with tuberculosis. In fact, healthcare workers are 6 times more likely to be infected with drug-resistant tuberculosis as compared to the general population. Although there are stories of cure and triumph, as many as 1 in 3 of healthcare workers may end up dying of tuberculosis. What is so remarkable about the people we have just introduced to you? Only one thing: their willingness to come forward, to open up, and to tell their stories. There is a deafening silence from TB patients all around the world, and this is a void that needs to be filled with voices, stories, sharing, and caring. So that is why we're here today. We want to talk about it. We want to talk about occupational TB. We want to talk about why the diagnosis is often delayed and how to prevent the spread in our healthcare facilities in order to make them safe for healthcare workers and for patients. Working in South Africa, we often forget that many other countries are fighting the same battle. We're not alone. In 2017, the World Health Organization Global Tuberculosis Report declared TB as the leading infectious killer in the world. Each day, almost 4,700 people die from tuberculosis. Over 4 million cases of TB were either missed or not reported on. In order to end the fight against tuberculosis, we need to find all the cases of TB and ensure that each of these persons has access to quality TB care. If you contract TB, it's not your fault. Tuberculosis is an airborne disease that is caused by a bacterium being spread into the air when a person with TB coughs, releasing small droplets of the TB bacterium into the air. People with TB of the lungs, otherwise known as pulmonary TB, or people with TB of the throat, also known as laryngeal TB, pose a risk of infection to others every time they shout, sing, or cough, or basically any action that expels air from the lungs. Basically, you get it from breathing, and everyone needs to breathe. After breathing in the bacterium, one of 2 things can happen. Your immune system can contain the infection, preventing you from developing TB disease, but bacteria stays in your body in an inactive state. This is called latent TB and affects around 1/3 of the world's population. With latent TB, you have no symptoms and are not infectious to others. There is a 10% lifetime risk that the TB bacteria can reactivate or awaken and cause you to develop TB disease. Alternatively, if your immune system is unable to contain the TB bacteria, you can develop active TB disease. TB usually affects the lungs, but almost any site of the body can be affected, and this is so-called extrapulmonary TB. There are several factors that can increase your risk of developing active TB disease. Your nutrition, having diabetes, cancer, HIV, using medication that weakens the immune system, or smoking cigarettes can also play a role. Other factors which may influence your risk of TB disease could include your workplace, like healthcare facilities and mines. Once you have had TB, you are at higher risk of getting it again. Most of the healthcare workers and students whom we worked with who contracted TB were fit and strong and had none of the traditional risk factors. Classic symptoms of TB include coughing for more than a 2-week period, unexplained weight loss, fatigue and fever, and night sweats. Sometimes people with active TB disease do not show any symptoms yet, and we need to pick this out soon by doing TB screening. TB screening would entail filling out a questionnaire on TB symptoms and having a chest X-ray done. Let's talk about the different classifications of TB according to their pattern of resistance. Drug-sensitive TB is the most common type of TB that one can get. It responds to first-line antibiotics, with treatment usually lasting 6 to 9 months. If the type of TB strain you have is resistant to rifampicin and isoniazid, then you have what we call multi-drug resistant, or MDR-TB. There is a common belief that you can only get drug-resistant TB if you take your TB medication incorrectly. This is false. If you can remember Zoe, Pat, and myself's stories, we contracted drug-resistant TB without having any previous history of having tuberculosis. Drug-resistant TB is treated with second-line antibiotics, and the therapy can take from 18 to 24 months in duration. The side effects to this medication are usually more severe, and the risk of death is higher. Further resistance testing is usually required and can take up to 16 weeks. If the TB strain is found to be resistant to the second-line antibiotics, you have what is called extensively drug-resistant TB, or XDR-TB. The treatment for XDR-TB is usually very difficult and the side effects are serious. Luckily, there is hope. Recently, 2 new drugs were introduced as treatment options to treat MDR and XDR-TB. These 2 drugs are called bedaquiline and delaminid. We need to make sure that these drugs are available for those people who need it the most. Many people face occupational hazards. Policemen, are they bulletproof? No. They take the necessary precautions and put on a bulletproof vest. And what about firemen? Are they fireproof? Of course not. They put on fireproof outfits before they go storming into a building and save lives. And what about us, healthcare workers? Are we TB-proof? Certainly not. We also need to take the necessary measures and protect ourselves from contracting TB. Now let's go and take a look and see what these steps are.
My name is Angela Dramoski and I'm a member of TBProof. I'm a pediatric infectious disease specialist with a passion for infection prevention and control, and I'd really like to share with you some information regarding improving TB infection control in your workplace.
When we speak about the spread of TB in healthcare facilities, it's important to know where to focus our efforts. In the past, we used to think about TB infection control when seeing a patient who was known with TB already on treatment. Unfortunately, this approach is incorrect. Patients who have TB who are already on effective treatment for more than 2 weeks seldom pose a risk of transmission. Patients who have TB but who are not yet on treatment pose the biggest risk of transmitting TB in healthcare facilities. This could be a patient with an unrelated problem, like a broken leg or a mother in the neonatal ward. It's therefore essential that we consider TB in any person we provide care to. When we do sputum tests, we should also use new technologies like GeneXpert that can tell us if it's drug susceptible or drug resistant TB, to ensure the person starts the correct treatment to reduce the risk of transmission. Streamlining the processes in a facility to identify people with TB and start effective treatment is the core component of the FAST strategy, which we will discuss in more detail later.
So as a healthcare worker, when are you at the highest risk of TB exposure? Well, essentially it's when you have not considered the possibility of a TB diagnosis. So when I'm consulting a patient or a family, my first question to them is anybody coughing? Is anybody on TB treatment? Is anybody getting injectable therapy, perhaps for drug-resistant TB? And this will help me do a quick risk assessment to decide, do I need to perhaps wear a respirator, open more windows, ensure that there's good air exchange? The other scenarios where TB exposure is highest is any time that there's forcible exhalation, so intubation, resuscitations, open suctioning, for example, on an ICU. Those are all really high risk situations for healthcare workers. And once the TB has been aerosolized, it will remain suspended in the air for several hours, continuing risk to any healthcare worker or person that enters that space. So how can we prevent TB transmission in our healthcare facilities? Well, TB infection control is not rocket science. In fact, it's quite simple. This patient with active TB is in isolation. The area and the space they're using is very well ventilated through use of natural ventilation, and personal protection is shown in terms of the healthcare worker wearing an N95 respirator and the patient wearing a surgical mask whenever the healthcare worker is in close proximity. So the World Health Organization uses a tool called the hierarchy of TB infection controls. These essentially are a system of ranked interventions which are used to prevent TB transmission in healthcare facilities. The first and most important are the managerial controls, followed by administrative controls, environmental controls, and lastly, personal respiratory protection. In terms of managerial controls, it's really about implementing TB infection control as a team. So every team needs a leader. So your facility should have a named individual who is responsible for implementation of the TB infection control plan. It's somebody that you can approach if things are not going to plan. It's important also to involve a large team of people so that there's buy-in from a critical mass of individuals at your facility. This is to ensure that everybody agrees and implements the TB infection control plan. The second step in the hierarchy of TB infection controls are administrative controls. These are really involved with the day-to-day running of your healthcare facility and should involve everybody that sets foot in your clinic or hospital. As clinicians, doctors and nurses, the first step when a patient arrives at your facility is to triage. So that's to decide who is actively coughing and to separate them to a separate area, provide them with tissues, teach them about safe cough etiquette, washing of hands and so on, and then to try and triage and get them to move through your facility as quickly as possible to reduce the risk to other patients. The laboratory is also a very important partner in TB infection control. They help us to confirm a diagnosis of TB, and particularly now with the widespread availability of GeneXpert, we've reduced the time required to diagnose drug-resistant TB from over 6 weeks to just 2 hours, and this is a major advantage in treatment of patients with TB. The infection control team and occupational health practitioner, if you do have one where you work, are also vital partners in implementing the managerial and administrative controls for TB infection control. The third step in the hierarchy of TB infection controls is ventilation. Not much has changed from the 1800s when patients were sent to the Swiss Alps to get fresh air and sunshine to tackle TB. So in many TB hospitals, particularly in Africa, we use this concept of natural ventilation to provide a safe space to care for patients with TB. Essentially what we want for clinics is a waiting area that's very well ventilated, preferably outdoors, and you could encourage patients in the winter months to bring blankets and things to keep themselves warm, because this really is the safest place to keep people together. What you don't want are closed, stuffy, confined places or windows that can't be opened because of burglar bars, because these prevent the flow of natural ventilation in a space and markedly increase your risk of TB transmission. So in hospitals, the requirement for ventilation is somewhat different depending on the resources you have available. Firstly, it would be ideal to have isolation rooms available to separate patients with active infectious TB from other patients. Preferably, these isolation rooms should be ensuite with bathrooms to prevent patients from walking through the wards, and they should be mechanically ventilated or naturally ventilated to remove any TB aerosols from the space. Also in hospitals and clinics, you need a safe space where patients can go to produce a sputum sample for TB testing, commonly referred to as a cough room. Cough rooms should be equipped with good ventilation and a hand wash basin to perform hand hygiene after producing a sputum sample. Clearly, these are not available everywhere, so often the safest place to send a patient is outdoors or outside, where there is fantastic ventilation and the risk to others is minimal. So the last element in the hierarchy of TB infection controls is personal respiratory protection. As a healthcare worker, this means using an N95 respirator for your protection. A respirator really is very different from a surgical mask. A surgical mask we reserve for patients with TB, and essentially that's because we're trying to trap the TB bacilli when they cough. Conversely, for a healthcare worker, we are trying to filter out the tiny TB bacilli that are floating in the air when the healthcare worker breathes in. It's absolutely essential that as a healthcare worker you are fit tested for the correct size and shape of N95 respirator for your face. Clearly everybody has a different face size and shape, and so personalization of this is important. In terms of surgical masks, it is important that a patient wears a surgical mask if they have active infectious TB and there is a healthcare worker or any person in their immediate vicinity, probably less than 3 meters. Although it's also important to remember that once the healthcare worker has left the patient's space, the surgical mask can be removed.
An N95 respirator needs to filter out the TB bacteria in the air in order to protect you. It cannot do so if the respirator does not form a good fit and a tight seal around your face. Otherwise, contaminated air with the TB bacteria may leak into your respirator and you may mistakenly think you are protected. A fit test will determine the proper size and type of N95 respirator to use. I am now going to demonstrate how to put on and take off a respirator. Open respirator and inspect for damage. Apply the respirator to the face, adjust the elastic bands or ties, and pinch over the nasal bridge. Remember, facial hair like a beard or a mustache can affect your respirator's ability to form a tight seal on your face and protect you. Perform a positive pressure seal test. Breathe out and feel if there is a leak. Perform a negative pressure seal test. Breathe in and feel if there is a leak. Remove the respirator, touching the elastic bands or ties only, or use a paper towel. Place the respirator in a labeled paper envelope. Wash your hands with soap and water. N95 respirators can be used for 12 hours continuously, so it's not necessary to throw them away after a single use. Check that there are no signs of damage, that the mask is not wet, and that the elastic bands or ties can still give a good seal. Store it in a paper envelope with your name on it. Where is the best place to put on your respirator? In a well-ventilated area and not next to a patient who is still coughing. Is there a simple way to remember the essentials of TB infection control? Absolutely. We have the following memory aid: fast flow masks, and it matches the WHO hierarchy we just learnt about. FAST stands for finding cases actively, separating coughing patients, and treating effectively. Finding cases actively means that every patient in the health facility should be screened for TB. Once the screening has taken place, we need to separate people with TB symptoms and those without. This is achieved by correctly triaging patients. The T stands for treating patients with the correct medication. We know that the right medication reduces the amount of bacteria in someone's sputum very quickly and makes them less infectious. Treating also reminds us that it's important to help patients complete their treatment course. Flow helps us to remember that there needs to be a flow of air. Simply opening a window but not feeling a breeze is not enough. Maybe try to put a fan to direct air towards a door, or open 2 windows on opposite sides of the passage. You need to feel the air flow. And finally, masks. Remember to give a patient a surgical mask and a healthcare worker an N95 respirator. We are now going to look at a few questions submitted by healthcare workers about TB infection control. How long does TB remain infectious? For how long should we implement TB infection control after a patient has started treatment?
We know that once a person starts effective TB treatment, their infectiousness decreases dramatically. That is why we need to focus on reducing the delay in diagnosis and starting treatment. To know whether the treatment is effective, you need to know if it is drug-sensitive or drug-resistant TB, and whether the symptoms are getting better. For drug-sensitive TB, we recommend implementing TB infection control for 2 weeks after the initiation of treatment. For drug-resistant TB, you usually wait for 2 negative cultures at least 1 month apart. Remember that extrapulmonary TB, like TB meningitis, lymphadenitis, and pleural effusion, are not infectious unless the patient also has pulmonary TB.
Once I am infected with latent TB, should I still continue to implement infection control measures, or is there nothing more I can do? Your risk of developing TB disease increases as long as you continue to be exposed to tuberculosis. It is never too late to start TB infection control measures. I know you said a patient should wear a surgical mask and a healthcare worker a respirator. But what if we don't have enough respirators? Would it not be better to give it to a patient? An N95 respirator is very difficult to wear. It makes you feel very hot and you can feel short of breath. Imagine if you were a patient with a lung disease and you had to wear it. You would feel very short of breath and start to cough. An N95 respirator needs to filter out the air in order to protect you. So no, healthcare workers are the only ones who can wear an N95 respirator, and patients need surgical masks. How often should I as a healthcare worker be screened for TB, and with which methods? Healthcare workers should receive annual screening for TB. This could be symptom-based and include a chest X-ray according to the Hazardous Biological Agents regulations. Are there laws in South Africa that protect healthcare workers against TB?
Yes, tuberculosis is recognized as an occupational disease in South Africa, and there is a legal requirement for employers to provide a safe working environment, personal protective equipment, and TB screening. If a healthcare worker develops TB disease, they are eligible for compensation according to the Compensation for Occupational Diseases and Injuries Act.
I've seen some of my colleagues putting on their N95 respirators when they are standing next to the patient who is being evaluated for TB. Is this correct? No. It would be best to tell your colleagues that they need to put on their respirators in a well-ventilated area. How can I persuade a patient who is coughing to wear a mask? I am worried I will make them feel stigmatized. This is best achieved by explaining to the patient carefully why they have to wear a mask. They are protecting those around them. Wearing a mask makes you a hero. Now let's talk about TB stigma.
Because now you will find in clinics people don't go to the clinic where they stay. They go to another clinic whereby they don't know, they don't know anyone there. They just avoid being stigmatized by the people from their own townships or wherever they stay. So there's a stigma attached around TB, be it normal TB or MDR TB.
Dis 'n bietjie van 'n eye-opener. Dis regtig om gediagnoseer te word daarmee. TB is oral. Dit is nie moeilik om geïnfekteer te word daarmee nie. Dit is regtig, dit kan so gou gebeur. Jy voel eers ongelooflik skaam asof jy iets verkeerd gedoen het. Iemand wat TB het ook niks verkeerd gedoen. En iemand wat TB het is steeds iemand. Hy hoef nie in 'n hoekie geskuif te word nie. Hy is steeds 'n mens.
Well, there is life after TB, after all. Well, the best way to eliminate this or to raise awareness about this is to talk about it.
Awareness in general is important. The only way you find out more about it is by being educated about it, and there's a lot of myths about TB. So spreading awareness is breaking those myths and breaking that stigma so that people can be treated, effectively, and we can prevent, cases of TB, because obviously in general, prevention is much better than cure.
Unfortunately, healthcare workers are also very stigmatizing sometimes in the language that they use. They use terms like TB suspects. In some countries, they even have a suspects register for TB. And so this term is really stigmatizing. Usually we use the term suspect as a criminal suspect or somebody that did something wrong, and so we suspect them of having done something wrong. And so this is really a stigmatizing term for TB patients. We suggest that people rather use the term, this person is somebody that needs to be evaluated for TB. Other terms that healthcare workers use are terms like defaulters. This refers to patients that have started treatment but then for some reason were lost to follow-up. Using the term defaulters or patients that has been non-compliant is incorrect because this assigns the blame completely to the patients. A lot of times the reason why they do not complete their treatment is reasons beyond their ability to control. Reasons like drug stockouts. In some countries, TB patients has to pay for TB medication, and if they don't have money, they therefore cannot complete the treatment. Other reasons like the treatment makes them feel so toxically ill that they realize if they don't take the medication, they feel much better, and so they can return to work. And a lot of times they are so scared to lose their job that they'd rather go back to their job than be able to visit the clinic for the treatment. Sometimes they have to visit the clinic on a daily basis, and this is just not possible for them if they want to keep their jobs in order to support their families. So we suggest people rather use the term patients that are lost to follow-up, because we don't know why they could not complete the regimen, and most of the times it's just because they did not have enough support.
Undergoing treatment for TB can be very difficult, and our patients need all the support that they can get. Now let's do a practical exercise to try and link what we have learned with the strategies for the health facilities where we are working. If you are in a group, pause the video and discuss amongst yourselves. If you're watching this video on your own, grab a pen and a paper and jot down some answers. What common goals unite us as healthcare workers? How can we link that with what we have just learned about TB infection control? What elements of TB infection control is your facility already implementing? What are you doing well? What area do you think you want to focus on improving first? Try to set a goal that is specific. How will you know you are making progress on your goal? Also, pick a time by when you would like to achieve it. Training sessions are vital in improving TB infection prevention and control, and it helps to reduce TB stigma. There are many professionals that work in a health facility. We have doctors, nurses, kitchen and cleaning staff, physiotherapists, porters, ward clerks, to name a few. We have to target them all because they are all at risk of being infected with occupational TB. Go out into your health facility and go into their environments. Find out what they know about TB infection prevention and control, and also find out where the gaps in their knowledge is. Interactive sessions using games and videos helps to keep people engaged and to remember your message. Here is a photo from Cecilia Makiwane Hospital in East London, where games were used to teach people about TB infection prevention and control. Give people a chance to ask questions and also to talk about their experiences with TB. Now let's do a quick recap on how to remember what TB infection prevention and control entails. Do you still remember the memory aid? I think you said fast flow mask. FAST stands for finding cases actively, separating coughing patients, and treating effectively. Flow helps us to remember that there needs to be flow of air. And finally, masks reminds us to give a patient a surgical mask and a healthcare worker an N95 respirator. What do we need from you? We need you to take ownership of your health. We need you to consider a diagnosis of TB in every patient. We need you to engage with your colleagues and your managers at your facilities to ensure that TB infection prevention and control measures are implemented. We need you to talk about TB. Talk about it to your colleagues, to your patients, to your family, and to your friends. Congratulations! After watching this presentation, you are now a fully qualified TB-proof champion. Show your support for the cause by arranging a screening of this presentation at your facility to a team that has not yet received training on TB infection control. Send us a picture of you and the group who attend the session, showing a zero sign or a mask to say you are helping to reach zero TB spreading in your facility and aiming to have zero healthcare workers or patients getting TB. Join thousands of other healthcare workers as we unite to end TB. We need you to be the difference every day and to help end TB.